It is my pleasure to introduce Dr. Brian Hasselfeld, the Senior Medical Director of Digital Health and Innovation at Johns Hopkins Medicine, focusing on digital health, virtual care, and clinical innovation. Dr. Hasselfeld oversees virtual care operational and technical implementation across all of Johns Hopkins Medicine, including hospitals, ambulatory operations, international home care, and the insurance lines of business. Additionally, he is the Associate Director of Johns Hopkins inHealth, a strategic initiative advancing precision medicine across JHM. He's also a primary care physician in internal medicine and pediatrics in Baltimore City, and is a board member for the Johns Hopkins Health Plan's Medical Advantage Insurance Plan. So thank you for being with us here today, Brian. We really appreciate it.
Yeah, excited to be here.
So I guess, can you start by just giving us a little bit about your background and the various hats that you wear at Johns Hopkins today?
Yeah, for sure. First and foremost, I'm a clinician, a primary care clinician, both boarded in internal medicine and pediatrics, as you referenced, seeing kids and adults in primary care here in Baltimore City at one of our community practices, and do that 2 days a week. Was in clinic this morning, and outside of that, spend the rest of my job here supporting anything digital and care delivery for Johns Hopkins Medicine. For those that don't know, here in Baltimore, anchored around the Johns Hopkins Hospital, now 125 plus years old. We deliver care across now 6 hospitals, 4 states, 50 buildings, and 1 million patients a year. Pride ourselves in discovery, care delivery, research, and innovation, and in that role, support how we use new technologies in our care delivery organization. I also work with our insurance companies and thinking about how we use technology from the insurance side, as well as our home care company, to help understand how we bring technology out into the home. But all of that is grounded on we can do better in using technology in how we connect patients and clinicians and caregivers across the continuum from in our hospitals to on our clinics. And fortunate then to also be able to extend some of that experience to companies that I think are making a difference, including serving as an advisor here to ShareWell. So happy to be here.
As are we. Could you share a little bit about your background? I know you had a stint in Wall Street, so would just be kind of curious about what brought you into medicine and the path that you took to get here.
Yeah, absolutely. A little bit of a winding road, and I think it's always good to, be reminded that always okay to make a pivot. Initially a computer science undergrad that went to Wall Street into tech, media, telecom, investment banking, and spent a couple years doing the traditional investment banking route, which involves thinking about mergers, acquisitions, financing companies. And around the end of my second year there, I came from a family born and raised in the Midwest, born and raised in St. Louis, and had a family back home with no clinicians, all from finance and accounting. One of my younger brothers went through an early cancer diagnosis during his college years. I was already working in New York, and we all flew home to St. Louis and went to one of the first visits with our oncologist, and flew back to New York and said, I'm gonna do a different job, take the MCAT, the test to get into medical school. Was fortunate that I had a boss at the time that understood some of that passion and the potential experience that we just had, and followed that path. Went down to med school in New Orleans, but really from that point forward, really thinking about the opportunity to create a different kind of care delivery experience. Really fortunate to have resources to be able to fly home and make that trip to be with family, but too often we force patients and care to be where the buildings are, to be where the clinicians are. And I think just a ripe opportunity to help innovate both in the care delivery model and innovate in the technology and how we connect patients, clinicians, and care teams. And so started working with a digital health accelerator during med school down in New Orleans, and continued that work ever since. Show up day one of med school and don't know a whole lot of medicine, but know a little bit about corporate finance at the time, and started helping with some business plans in early stage companies, and really continued to combine those two threads throughout med school, and then residency, where kind of did a double major in residency, learning both internal medicine, which is kind of the discipline in general medicine. Most adult primary care clinicians have some internal medicine training, and then also in pediatrics, so general pediatrics for general pediatric care, and doing both of those in Boston, and then finding my way down to Baltimore, where we've been now for 5 years.
Awesome. Yeah, I think one kind of manifestation of that.
Sí, o sea, pero nos tenemos que bañar. Ándale, porque ya me tengo que ir. Bueno, el agua calientita, ¿ok?
One manifestation of that sort of breadth of experience I've seen is that you explain complex healthcare issues and systems in kind of a nice, succinct way, in terms of supply and demand, or like kind of these are the real issues that we're facing, and this is how all these kind of complex new technologies may help to overcome them. So I guess I'm curious both in terms of your role and just the subject at large, what are we trying to accomplish with digital health innovation? So what are the biggest challenges that we face today and that innovation could potentially solve for?
Yeah, I think referencing a talk that I gave just a few weeks ago to HIMSS, which is a big organization focused on technology and healthcare. Anyone that has tried to navigate getting care, any kind of care, over the last few years recognizes just how hard it is. Just how hard it is to both find the care that you need, but also get that care in a timely fashion. So, that manifests in a regular market-based industry, not in healthcare. People needing more of the thing than is supplied would result in increasing prices. And for a lot of good reasons, that's not the right pathway for us to take in healthcare, although there are some high prices in healthcare, to be sure. But in the unique industry around healthcare, traditional healthcare access, with contracted insurance rates that both the clinician and the patient don't really control, what happens then is that we wait longer for the care that we need, since price doesn't have a natural mechanism to balance those two things out. And, both myself, my own care, my family members' care, certainly my patients' care, we all know just how long sometimes we have to wait for care. That's particularly true in mental health. It's true in a lot of other subspecialty areas in medicine in general. And so we need to do one of two things. We need to unlock more supply, so innovate around the care delivery model. So that's things like finding different types of skills that can support the care team in different ways, ranging from peer support to nursing staff to allied health and our advanced practice providers, to other forms of clinicians that may want to deliver care differently, including virtual care, where a lot of different types of clinicians can deliver extra care what they otherwise didn't want to do inside of a building, or thinking about the way that technology can make care more efficient. So a patient goes through a lot of waste in trying to get to the right kind of clinician that they need for the particular health question that they may have. That waste may come in a wide range of different forms. It could be going to a specialist that didn't exactly care for that kind of question. It could mean going to one clinician, changing insurance, and then not being able to go back to that clinician. It could be getting a test that you didn't need, or a test that took you down the wrong pathway. So there's a lot of information in healthcare, but we really leverage that information relatively poorly, I'd say, in delivering precise medical recommendations for you, healthcare recommendations for you. So it's both. It's both care delivery model innovation, unlocking human supply of extra care, and then technical innovation. How do we care for more people with the same number of clinical team members, and merging those two things together across the care continuum, outpatient or ambulatory to inpatient to mental health to other forms of physical health and everything in between.
That's great. Yeah, and we've also seen with the pandemic that innovation could be could be proactive, could be solving for things that we know exist, but it could also be very reactive. So
Yes.
I was wondering if you could tell us a little bit about, rewinding to the end of 2019 and the beginning of 2020, what things look like at Johns Hopkins before and after.
Yeah, it's important to tell this story, right? I mean, I think the world is such a fast-moving place at this point in time. It's hard to have a long-term kind of recollection, and that leads to kind of recollection bias, where you kind of forget exactly what things were like beforehand. And certainly healthcare took a major shock to the system. The world took a major shock with catastrophic loss of life and catastrophic loss of life, a major public pandemic. And we all realized that there was going to be a need to deliver care quite differently. We had a lot of confluence of events that happened at that time, and it calls out the importance of the public policy, public realm, and thinking about how we influence a major portion of healthcare, as well as a major portion of the economy, a major industry, and the role that public policymakers have in that space. So at our particular institution, but also true across the board in major healthcare, we were doing 2 to 3 virtual visits a day. So 2 or 3 visits a day across the 1 million patients that we care for in a given year. And then by May, June of 2020, we were doing 5,000 a day. So 2 to 5,000. And that same kind of trajectory was represented across most big health systems. And so that is truly transformational change in what we felt as clinicians, what everyone felt as patients, in kind of being forced, right, to think about how you connect with clinical teams differently, out of, hopefully for safety reasons. We didn't know a lot at that time in March and April of 2020, but also recognizing that everybody can move fast when there's that kind of shock to the system. Healthcare, for very good reasons, is well known for moving slower, right? If you or a family member go to any type of healthcare, you don't want to be tested on, you don't want to be experimented on outside of regular research. And so you certainly don't want to say, let's try this other way to get your care, unless there's some good reasons to do so. But in 2020, we really did have some good reasons to do so. And so transformational change in how we connected patients and clinicians, but also transformational change and pace of change in public policy and regulation. And in healthcare, we have a number of things that need to move. It's really never only about the technology, right? It's about what kind of care do patients want? What kind of care can clinicians provide? It is an industry, so what kind of care is compensated or reimbursed? What kind of care is permitted by law and regulation based on safety, quality, and including important considerations like equity and access to care too. And so, all of those things evolved very quickly in March, April of 2020. It allowed us to experience what kinds of care can be conducted when there's more flexibility. Not everything was perfect, but it did help us learn a lot about connecting clinicians and patients via technology. As an example of what isn't exactly perfect, I think there is a major equity component when thinking about how we access care through technology. Not all technology is equally accessible, to be sure. Not all healthcare is equally accessible, to be sure. We've published some of our data around the importance of different forms of remote access here at Johns Hopkins. We published a paper highlighting that some of our patient populations who are most disadvantaged in accessing care through historical biases and prejudices, as well as current socioeconomic factors, actually use more virtual care. It's just that some of that care, a lot of that care, was done through telephone, so low-tech interventions relative to other higher tech, doing what we're doing right now, accessing through video and conferencing, which requires access to data and broadband and high-speed internet. So this balance, that remote care can deliver benefits across perhaps the equity spectrum, but not all kinds of remote care is equally accessible. So a lot of flexibility, 0 to 100, things changed very quickly, and that was across regulatory, payment, clinicians, care teams, and then some important considerations when we think about, are we ensuring that we're making that same care accessible across the continuum of patients that we serve? We like to think that that can also address some other historical inequities, right? I'm not sure if anyone's ever tried to park at a big hospital recently, but it's quite expensive. Public transportation isn't exactly this country's strongest suit either. And so some of the benefits that remote care can bring, again, I think are important, but there's always balancing things to consider.
Yeah, and I think since we have around 10 minutes before the Q&A, I want to shift from this kind of unexpected thing, the pandemic, which really shifted your trajectory and accelerated the pace of digital care that you guys are providing, to not, 3 years later, when we're seeing the introduction of generative AI and major advancements there. It's a lot to have happened in 3 to 4 years. So shifting the conversation to AI, I want to just sort of ask a couple questions about how you and how Johns Hopkins is approaching it. I guess to start, could you define AI or generative AI as it relates to healthcare and kind of how you think about it?
Yeah. Well, I think this is a really important time. Again, I think across multiple areas of the economy, and then certainly inside of healthcare, multiple areas about how we're thinking about delivering care as clinicians, how I think many patients will start to think about accessing care and everything in between. The term artificial intelligence is obviously not new, been around for a long time. But historically, we would think about writing computer code, creating a program, having an algorithm that you can understand the inputs and the outputs, and actually be able to debug and think about what went wrong, as I'm sure Brett well knows in thinking about creating products. Now, though, we're on what would probably be called the third wave of this term artificial intelligence. It carries the moniker generative artificial intelligence, and that is built on this new technology, large language models. And that technology is built on the T in GPT, which is transformer technology. So now, kind of out of the blue, we have a very, out of the blue, at least for most of us, many in technology maybe could see a little bit of this coming. We have this massively available new technology that is meaningfully intelligent, and I don't use that word lightly, that is understanding of the human language, which is our most common interface. That's how we as humans interact, is through language, whether it's spoken, written, visual, symbolic. We interact on the ability to communicate through language. And that has actually been one of the biggest barriers in leveraging massive amounts of data in healthcare. What do you do when you go to a clinician's office? You talk, you tell your story, you try to convey what you're feeling. You are asked a number of questions from a trained professional. That is really what we're trained in as clinicians. We're trained to extract. We're trained to extract relevant information about what you're experiencing, about the human condition. And so most of the information in the medical chart is actually stored in the human regular free text narrative, the notes. It's not stored in lab values or imaging reports or tissue samples. It is stored in the vast amount of discussion that has been had. And so now we really have this new technology that can ingest, understand, and potentially, interpret, summarize, create new understandings around a large amount of data in a really, really short period of time, something that would take humans a lot of time to do. And so this is one of, if not the largest technical shock to healthcare in particular, in my opinion, given how our data is stored in language, free text, and notes and storytelling, and what this technology can do across the human language paradigm. So I really don't think it's an understatement to say that this is the largest technical shock, I think. And that's inclusive of 2020. And what that means is, for the first time, the ability for technology to start to do that second thing that we talked about. So we talked about care team redesign, we talked, a little bit about technology through virtual care can connect people to other people a little bit more easily, but I'm still one person and you're still one patient. That's one-to-one. This technology could really potentially scale me to one-to-many in a really rapid time frame. And I think it's both exciting and a little bit scary, to be quite honest.
Yeah, I think that's one of the nice kind of succinct ways that I've heard you put it, is like we have a limited supply of healthcare workers and mental health care workers, therapists, that what are the ways that we could like scale that and allow people to reach more with the limited time that they have. Are there other aspects of the patient care journey that you think are particularly inefficient, that you think will benefit from AI in the coming years?
It's a little bit easy to just say all of them, but I do think we spend a lot of time trying to get to the right place, right, in our care journey, and as a primary care clinician, I think we serve a really critical role in the broader healthcare ecosystem of being the place you go to try to figure out where to go next in a lot of ways, and that's a really important role, to be the efficient triager. But not all triaging capability is distributed equally, right? Not everyone has a primary care clinician. Not every primary care clinician has access to a big specialty network. Not everyone has a phone a friend. Some people can phone somebody that they know. And so, I think when we think about how do we get people faster to the care that they need, there's a lot of opportunity here. There's already been and these are N of one examples. So, right, and anyone that's done research and statistics, we all are emotionally connected to powerful stories. There's still one story inside of the broader healthcare landscape, but they still need to be told, right? USA Today, I think, had a big article about a parent that had a child that had a difficult time in figuring out what exactly was going on with their child, right? I'm a parent. Many parents know this sensation of saying something's wrong, something's off. And that parent, putting all of the medical information into, I think it was ChatGPT, and getting actually at the top of the list of things that could be wrong, the actual thing that was wrong, despite a dozen or more specialists, right? And helping point them to the right direction, not doing the care, not prescribing things, not saying this is a diagnosis, but simply helping think about things that maybe weren't considered because the amount of information is so vast, right? So most clinicians care for 1,000, 2,000 patients, and care is getting more complex. So how do you deliver precision, individualized care across a big data stack when there's so much care that needs to be delivered? So I think really this triaging function is really ripe for intervention. Has to be done safely, right? We don't want anything unsafe, untested, lack of quality control. But I think that also represents the next most important point. Nobody gave ChatGPT a license to make that recommendation to that mom. No one asked mom to be qualified to give their child's history to this agent to make that recommendation. This is truly a direct-to-consumer technology. It's available, it's there, and its data computational power is vast. And so I think we have to all think about how do we help that serve our patients, our clinicians who are also struggling, to help simply care for our fellow people as best we can. But I think the opportunity, again, is pretty big.
That is great. Yeah, and I think to kind of call out the safety aspect of it is important, because it is so limitless. It's a really mind-bendy topic to even think about. There's like the futuristic, like can AI replace doctors kind of piece, which doesn't seem realistic short term, but what it will do short term is empower doctors and clinicians and people interacting directly with patients to do their jobs more efficiently and have more information. And it's just like you said, it's kind of creating the safeguards to like use that information wisely, that I think will be really complex and a challenging kind
Definitely.
of area of thought.
There's an important one of my colleagues in an interview about a month ago highlighted that if all of us have been patients, we all know what it's like to go to a doctor's office. We don't go there to give our symptoms and then be read a textbook, right? We're not going there to have algorithmic intervention most of the time. Sometimes you kind of need one thing, get that one thing. But a lot of the times we're going there at least partially, and maybe even more true in mental health and related areas, but we're going there also for the emotional connection, understanding, the empathy and compassion that comes with being ill and receiving care, right? So there's going to be this blend as we move forward, even in areas where it's not so emotional, let's say driving, we still hold automation to a much higher standard than we do the human equivalent, right? Self-driving versus human driving. We could all look up the statistics about what's safer. So that's driving, which risks life and some major issues, but it doesn't carry that same emotional connection here. So if we think about the same paradigm, that healthcare really isn't only about a predictive answer or the next exact diagnostic step, but it's also about human connection. And I do think we need to be thinking about this together. The blend of how does the technology help the clinician and the patient get more efficient, but still empathetic and compassionate care all at the same time.
Thank you, Brian. I could talk to you about this stuff for hours. And I think we all don't know that much about it, both on the AI side and the U.S. healthcare system and internationally healthcare systems are really complicated. So like combining those two complicated topics into one conversation is really challenging, especially on Sunday. So appreciate your just so pithily explaining how things are kind of steering. Any final thoughts, Brian, before we wrap things up?
No, I think well, yes, but nothing too provocative or earth-shattering. But it is a reminder that it's easy to get lost in the technology. At the end of the day, we all know what it means to connect between patient and caregiver, and whether that be peer, licensed, family member, doesn't matter. And this is really a truly unique industry to be in. It's a unique profession to be in. And so I think, no matter what we do, continue to take the fellow human condition at heart. It's a special place to build and solve, and appreciate being here with a group of people that seem very equally like-minded and trying to address a really important problem for this country, for many other countries and beyond. So thanks to you, Brett. Thanks to ShareWell for the innovative work that you're doing and innovating on care delivery models. And I'm excited for the rest of the week.
Likewise. Thank you. Thanks everyone for joining.